The session is Dr. Sandeep Mutta, who by virtue of being the organizing secretary of this meet has requested us not to consider him for any award.
I will be going away from anesthesia, respected chairperson. I will be presenting on cardiac sympathetic blockade for intractable ventricular tachycardia. Many patients with previous myocardial infarction or cardiomyopathy come with ventricular tachycardia, which can be repeated. They can be hemodynamically stable or unstable. So basic mechanism is autonomic nervous system. It plays an important role in genesis and maintenance of ventricular tachycardia. Antiadrenergic intervention by pharmacological, that is beta blockers, is a well established treatment for this. As a conventional treatment, stabilization of hemodynamics, control of ventricular tachycardia by suppressing the electrical storm which is leading to ventricular tachycardia is done with beta blockers, antiarrhythmics, sympathodiuretics, DC shock and the supportive treatment. The cardiac sympathetic fibers are the afferent fibers which are excited by myocardial infarction, leading to excitatory sympathetic response, which in turn leads to ventricular arrhythmias and ventricular tachycardia. Modulation of neuraxial efferent pathway by thoracic epidural blockade is a therapeutic option for ventricular tachycardia. Epidural blockade lengthens the repolarization and prolongs the refractory period. We had 16 patients with ventricular tachycardia. Despite of pharmacological treatment and repeated DC shock, the tachycardia repeatedly occurred. The total number of therapies which were conducted before we went for thoracic epidural was 15 average. Out of the 16 patients, 11 patients were of cardiomyopathy and 5 patients were the post-bypass surgery. These post-bypass surgery patients were on ventilator basically. The pre-procedure arrhythmia treatment management, which I had told earlier, contained of beta blockers, antiarrhythmics, sympathodiuretics. They were on supportive treatment with inotropes and vasopressors. Multiple DC shocks were given to convert them. They used to convert intermittently and go back into VT. Anti-angina treatment, electrolyte balance was maintained and the supportive treatment was given. This is the thoracic epidural ECG of the patients. This is one of the patients where we can see that the complexes are broad. It's a ventricular tachycardia which is there. For the procedure, we went for T2, T3 level, as T1 to T4 are the cardiac sympathetic fibers. 18 gauge epidural was used. After epidural was confirmed, a bolus of bupivacaine 0.125% in a titrated doses were given. The titrated doses were 3 ml. We saw the hemodynamic changes and then repeated with 3 ml. The total bolus, average bolus required was 8 ml. For maintenance, bupivacaine of 0.0625% at a rate of around 4 to 6 ml titrated to the response which it gave. The basic monitoring with ECG, pulse oximetry, end-tidal CO2 for the patients who were ventilated, CVP monitoring for the patients who were not in the post-operative period, PA monitoring for the patient who were post-bypass. Oxygen was instilled continuously. These patients were normally hemodynamically stable because we had stabilized the patient earlier. After 1 hour in the post-CABG patient, the ECG looked like this, where there was some ectopics which are coming. The rate had come down. The tachycardia, ventricular tachycardia which was there had settled, but still some ectopics were there. In post-bypass patient group, 4 out of 5 patients showed reduction in ventricular tachycardia and episodes by 80%. And in cardiomyopathy group, all the patients responded by around 80 to 90% decrease in the incidence of ventricular tachycardia. At 6 hours, in the post-CABG group, 90% were controlled, and in the post-cardiomyopathy group, around 95% control was there of VT. So we required only 3 patients in the post-cardiomyopathy group where the DC shock had to be given after instilling thoracic epidural to convert them into sinus rhythm. This is 24 hours later, the ECG had stable, the ectopics had gone, and you can see it's in the sinus rhythm, but the PR interval is longer. In the post-CABG group, one patient required permanent pacemaker implantation. In the cardiomyopathy group, they after they were stabilized with transesophageal, with epidural treatment, they went for the EP study. The electrophysiological study was done. 8 patients went for ablation, 5 patients went for permanent pacemaker implantation. Out of the 8 patients which went for ablation, 3 required thoracoscopic excision of sympathetic ganglion. These were the references which were there, and this study is still going on. So, actual demographic data, this was not given in this one. Thank you, sir.
Thank you, Dr. Sandeep, for an excellent presentation. We started at 10:07, we finished at 10:07, so that's good. Sorry for running late. Though only a few of you will be considered for awards, I would like to say that all of you deserve accolades for the effort that you put in. So I'd really like to congratulate each and every speaker on behalf of both my judges here for the effort that you people have put in. So what we will be doing is, we will be giving these evaluation forms to Dr. Sandeep Mutta, and he will tabulate all the 3 results, and the results will hopefully be announced to you before this evening. Thank you very much for being here.